Post-stroke seizures are a common and clinically significant complication of stroke. They represent one of the leading causes of acquired epilepsy in adults, particularly in elderly. Clinically, post-stroke seizures are most often focal in onset with or without secondary generalization. From a clinical and pathophysiological standpoint, seizures after stroke are broadly classified into early and late seizures, and this distinction is very critical. Early seizures occur within the first 7 days of stroke. These are acute symptomatic seizures resulting from transient biochemical and physiological disturbances. These include ionic shifts, glutamate mediated excitotoxicity, and cerebral edema. Early seizures do not imply epilepsy, and their recurrence risk is relatively low. In contrast to this, late seizures occur after 7 days. These reflect structural and functional reorganization of the brain, including gliosis, synaptic remodeling, and network hyperexcitability. Clinically, post-stroke seizures are most often focal in onset with or without secondary generalization. They may present with focal motor activity, behavioral arrest, aphasia, or even subtle non-convulsive states. In hospitalized or ICU patients, unexplained altered sensorium should always raise suspicion for non-convulsive seizures or status epilepticus, and here EEG becomes essential in such cases. Now, an important question in practice is which patients are at higher risk of developing epilepsy. Early seizures are the strongest predictor of later epilepsy. The other predictors are cortical involvement, large impact size, hemorrhagic stroke or hemorrhagic transformation, severe stroke, and a high NIHSS score. To quantify this risk, the SELECT score was developed and validated in Lancet Neurology. It incorporates stroke severity, early seizures, large artery atherosclerosis, early CT changes, cortical involvement, and MCA territory involvement. The diagnostic approach to post-stroke seizures is systematic. First, a careful clinical history is essential, including the semiology and timing of events. Neuroimaging, preferably MRI, helps identify cortical involvement and structural lesions. EEG is particularly important when there is an altered sensorium or suspicion of non-convulsive seizures. Lab evaluation should exclude metabolic triggers such as hypoglycemia, electrolyte imbalance, and infection. Coming to the treatment, routine prophylactic use of antiseizure medications is not recommended after stroke. If an early seizure occurs, short-term treatment may be considered, particularly in high-risk patients. However, long-term therapy is generally not required unless seizures recur. In contrast, a late seizure should be treated as epilepsy and long-term anti-seizure therapy is indicated. Among medications, levetiracetam and lamotrigine are commonly preferred due to their favorable side effect profile and minimal drug interactions. In summary, early seizures are acute and transient. Late seizures represent epilepsy. Cortical involvement and early seizures are the key predictors. The SELECT score helps estimate the risk. And importantly, anti-seizure medications should be used judiciously, not prophylactically. Thank you.